We're going to go over the perspectives on psychological disorders, and I'm going to explain to you what a basic idea of a psychiatric intake will look like. These here are the 7 major perspectives of modern psychology, and we will look, when we look at psychological disorders, at what each one of these perspectives has to say about what causes a particular disorder, or in some cases also how to treat a particular disorder. But before we do, let's look at the history of psychological disorders and the medical model. I know in the last set of slides I gave you, I talked about some of the history of like how people explained mental illness and how they treated it. And I started to explain really how the medical model got ushered in and really why it was so much better than what we had before, although still imperfect. So a psychological disorder, to remind you, is something that causes dysfunction, where the behavior is atypical, it's disturbing, maladaptive, unjustifiable, harmful. It's going to cause distress, disability, or both. That's really important. And it also really needs to impair your life in some sort of way for it to be a disorder. Again, if you think about that, like when we looked at statistical infrequency, like obviously it would be statistically infrequent to have somebody have an incredible gift or genius in a particular area, like Einstein or Feynman. But if it functions for them, it's not a disorder. So there are a number of criteria that we'd want to hit along the way to make sure that it's causing distress, disability, or both. And obviously, the point in identifying that would be so that we can help it, so that we can alleviate the symptoms. Help to, in best cases, cure something, and, worst cases, compensate and adapt. So this medical model, which was really a result of Pinel, remember that French physician who was working in an asylum and unchaining people from the walls, right? This medical model that gets ushered in is this view that psychological disorders are sicknesses and they may be cured through therapy. So diseases have physical causes that can be diagnosed, treated, and often cured. And this does cause hospitals to begin to replace asylums. Think Rosenhan's study. So obviously there's some limits to this, but it's so much better than what it was. And with that, mental illnesses are viewed as these diagnosable disorders of the brain, again, that cause distress, disability, or both. And while we will look very carefully at the different perspectives and what they have to say about different disorders, the biopsychosocial perspective is this idea that all disorders can be explained in terms of nature and nurture. So some disorders appear across the world, while others, in particular cultures, the mind and the body are inseparable. So this biological world you have, the social world you have, your psychological world, they all go together. In which case these problems are going to be caused by and also influence each other. And then lastly, we have the DSM-5. So the DSM is this American Psychiatric Diagnostic and Statistical Manual of Mental Disorders. We are currently at DSM-5. I want you to note a couple of things. First, that this 5 right there is not a Roman numeral. The previous DSMs were all in Roman numerals, and so they changed to a number system so that they can make more frequent edits without a big overhaul. So they can do like a DSM 5.1, DSM 5.2. So if you're going for some type of mental health treatment, insurance companies will usually require a DSM diagnosis before they agree to pay for the services, although there's a number of different ways that can be done. So obviously, like if you're diagnosed with something like clinical depression or schizophrenia or substance abuse disorder, that's pretty cut and dry. And in some cases, it could be something as like an adjustment disorder, where there's been some sort of change in your life that you're having a little bit of trouble adapting to. The type of diagnosis will also sort of give an indication to all parties involved as to really like what kind of therapy is best and also how long of a duration one can expect you to be receiving therapy. What the DSM has really done for us, though, is it has standardized the way we diagnose and treat disorders. It helps communication between professionals. So if somebody says to me that like, oh, well, this person has clinical depression, I will know very specifically that they have one of these 9 symptoms, right? So they're going to have a depressed mood or they're going to be anhedonic. One of those 2 things are going to be there. And they might experience like weight loss or gain or insomnia or hypersomnia, etc. Like I will know specifically what they are talking about and the clinical levels at which somebody would need to present in order to get that diagnosis. The DSM doesn't really give you as good of an idea as to the degree of the disorder, but it's enough that like professionals all know what they're talking about. You mention this disorder, and we all know. You want to understand too that the DSM has been a little controversial over the times. Like if you look at the history of it, they've had at times things classified as disorders that are not. So, like for example, I think I guess when I went through a program for this, I was using the DSM-4 TR. The DSM-5 is relatively new, but when the DSM-3 was out, they had homosexuality as a disorder, which it is not. And that was removed, and rightfully so. And so there are going to be those types of mistakes in there. We were in class together. I think I would do more to explain some of the controversy going from the DSM-4 to the DSM-5. It's not a perfect system, but it certainly works well enough. Again, in class, it would be interesting to compare the changes made in the DSM-4 to the DSM-5. And kind of talk about what that means and the implications of some of that stuff. But here, where I can't really interact with you that way, I'll let it go. But you might find it interesting at some point to explore the differences and also to look at why some of the changes to the current DSM were a little controversial. So one major perspective is the psychoanalytic and psychodynamic perspective. And this is basically saying that the psychological problems that somebody might be having are a result of unconscious, unresolved conflicts. So as an example, somebody who follows the psychoanalytic or psychodynamic perspective might say that like, okay, you're having issues with a mood disorder, let's say, because you have this anger, you're turning anger inward against yourself. So maybe that's due to a relationship or attachment loss or fixation. And this anger is going to come from these feelings of rejection or withdrawal of affection. And when you're looking at this stuff, think Freud, think Horney, think Jung, think Adler. The behavioral perspective would say that there's been inappropriate conditioning or modeling that's causing the behavioral or whatever the issue is that you're dealing with. So in the case of, let's say, an anxiety disorder, they would say, all right, well, you have this anxiety disorder because of maladaptive learning. So it could be classical or operant. So let's say you have a phobia. Well, that's conditioning. They could explain it in terms of conditioning. It may not be, but that might be how they explain it. In terms of modeling, they might say, all right, well, you have this anxiety because you had overprotective, fearful parents as a model, and they caused you to be afraid. You could have vicariously learned fears through parents that have modeled being afraid of certain things, unreasonably so. Again, these are just examples. The cognitive model would say that you're experiencing something due to faulty thinking about it. So in the case of, again, anxiety disorders, if you have cognitive habits that make you prone to fear, like a tendency to be hypervigilant or constantly scanning the environment for signs of danger and ignoring signs of safety. If you magnify ordinary threats and failures, so thinking you failed even when you haven't, or if you're extremely sensitive to criticism, if you have a really good imagination, these things could, this would all fall under the cognitive perspective that would increase your likelihood of anxiety. And if you think Aaron Beck and Albert Ellis and their cognitive distortions, anxiety and depression are treated rather well through a combination actually of cognitive and behavioral psychology. The biological perspective of psychological disorders would say that the mental illness or problems that you experience would be a result of brain function, genetic predisposition, or biochemistry. So if you take people who are depressed, let's say they've noticed a decrease in the amount of gray matter that somebody might have, or a decrease in frontal lobe functioning, specifically left frontal lobe, which is associated with like positive moods, that would be less activated. We see structural changes as a result of certain mood disorders, or there'd be an imbalance of neurotransmitters like serotonin or norepinephrine, dopamine. So the neurotransmitters that affect the symptoms of depression, like arousal, hunger, sleep, and wake. So the sociological or cross-cultural perspective would say that the problems with mental health would reflect cultural values and beliefs. You might note that in some cultures, people would be more likely to explain like physical symptoms of problems they might be having, and less likely to explain the personal level of distress that somebody is feeling. So some cultures selectively express or present some symptoms in acceptable ways and not others. Different cultures will also vary with the meaning that they impart to illness. Their way of making sense of subjective experience of illness and distress will vary based on your culture. And remember, this is part of the reason why we see certain illnesses in some cultures and not in others. As I mentioned before, like obviously eating disorders is more of a Western problem. In Japan, the number one phobia is making a fool out of someone else, where here it's mostly making a fool out of yourself. The evolutionary perspective would say you have this exaggerated form of a response that's really adaptive. So if you take something like depression as a for example, the evolutionary perspective would say that depression is there because it may be an adaptive response to a loss that helps us to reassess our goals that we wouldn't otherwise do. And the humanistic perspective would say that mental illness comes from blocked personal growth. So if you think of Maslow's hierarchy of needs, you know that people that don't have their physiological needs met or are not safe, they're not worried about education and meeting their full potential. They've got things that are more urgent to focus on. And so a mental illness from this perspective could also be the result of an overly demanding self-concept, particularly in the cases where positive growth is blocked. Okay, so I want to look at an intake with you guys. So if somebody were to come in for psychiatric treatment, they would, the person seeing them would need to do an intake. And at the end of the intake, they really want to have a diagnosis, if a diagnosis is to be made, and an idea of what type of treatment plan would be necessary. It is reasonable to expect that it would only take, say, a session or two, maybe max 3, I think, for somebody to kind of get a lock in the direction that they need to go in. And so if you meet somebody the first session and it doesn't seem to be working out, you might want to give it a couple sessions before you give up on it. But at some point, you want to make sure, and rapidly within the first few sessions, you want to make sure that you're getting a little relief from your symptoms. That's not to say that you'll be cured of them right away and that treatment will be super fast like that. But the act of going to therapy in itself often helps to alleviate some of the symptoms. So give it a few sessions, and if it's not working out, then it would be appropriate to, look elsewhere for somebody that might be a better match for you. Now, the first thing, if you were coming in and I were to do an intake, the first thing I'd want to know is your complaint. So why are you here? Why have you come to see me today? This is the patient's explanation of what the problem is. They may not actually know. They may not know what the heart of the issue is. And that's really okay. When they tell you what's bothering them, that of all things, regardless of the disorder that they might get, that they're telling you what they want help with. And that's an appropriate first thing to focus on. The next part of the intake assessment would be the PPE, the psychiatric psychosocial examination. And here you kind of want a picture of what the person's, living situation is like, what their lifestyle is like. So what is their family background? Do they have any, psychiatric history? Do they have any substance abuse history? Because you got to know, like, right off the bat, if there's problems with substance abuse, that's going to block your ability to treat a lot of other disorders. And with that, we'd look at, personal history, with struggling with psychiatric stuff, what you present as being important, your employment or school history. And here we'd really want to know your work and educational goals as well. Like, are they realistic? Are you on track to meet them? Want some social and religious ideas. It gives us an idea of some of the constraints or some of the potential problems that you could be having, right? Any legal issues we need to know about, the type of physical condition you're in. And you don't have to explain all of this to somebody. A lot of it they're going to just observe. So you're like, we're going to get a read on your overall mood. We want to find out about your living arrangements, who you're living with, where you're staying, whether or not it's affordable, that sort of thing. But know that, like, you could, depending really on who you're going to see, you could get some people that are working with you who have like this checklist of questions and they're going through and asking you what they need to, and that's okay. And I think this part, it's easy, kind of an easy place to start in an intake because, after the complaint, because it's the stuff that people talk about more easily, right? And you can be noticing a lot of other things. So obviously, like, if I find out in the psychiatric psychosocial examination that you don't have any issue with substance abuse, which I'm going to ask you in the next part as well, but if you don't have any issue with it, it's like that drop-down menu doesn't go down, and I'm not going to ask you a million questions about it. I want to see everything really as being a drop-down menu. If you say yes to something, then I explore that further. And so any one of these things, if there seems to be an issue in there, then I'm going to be exploring that further. If there's no issue, then I don't have to worry about it. A lot of this can be handled, though, again, without a checklist per se, but, just via conversation. The next part of the examination, and the reason why you wait till later, some of this you might have observed already, and it gives you an idea of some of the areas that you need to explore further. But all right, so this problem that you've reported, how long has this problem been going on? What is the duration? Is it new? Has it been something that you've been dealing with for years? I would need to know. The use of substances. So if you are using substances, when did you start? Which substances are you using? This is alcohol, amphetamines, barbiturates, cannabis, crack. I'd need to know. Then I want to kind of check if you're using substances for signs of abuse or dependence, because if you are struggling with that and there's another issue, there's comorbidity, more than one issue at a time, I need to clear up the substance use before I can really get to the treatment of the other stuff. So I would be checking for signs of substance abuse and dependence, but also current signs of intoxication or withdrawal. I'd want to know if you were ever in recovery or detox, rehab, AA, NA, that sort of thing. What was your longest period of abstinence from a substance if you're using? Now, again, if you are not using substances, there's no point in me asking all those questions. And while we're talking, I'm going to want to notice things about your appearance and your behavior. So, what is your attitude like, right? Are you argumentative? Are you whatever, what's the general mode you're coming in with? How are you with making eye contact? If you're not making good eye contact, where are you looking? What about your motor activity? Are you fidgeting a lot? Is there like psychomotor agitation with these fast movements, or psychomotor retardation, this slowing down of your movements? I'd be watching for that sort of thing. Then we get to speech. What's the rate and volume of your speech? What's the quality of your speech and the quantity? What types of things are you talking about? When I get to cognitive functioning and intelligence, Um, I want to know, are you oriented to like the person, date, and place? You know, who you are, where you are, when you are. I might want to know if you could take a simple word like earth and spell it backwards. And maybe I will tell you some, like maybe three disparate objects. And then 5 minutes later, I can ask you to recall those disparate objects and to see if you can. What is your long-term memory like? What is your fund of knowledge like? And your overall like intellectual capabilities. I'd want to note that as well. Looking down at your mood, affect, insight, judgment, thought processes. When you're describing stuff that's really upsetting, is your affect reflecting of that? So do I see the appropriate emotional response? What your thought process is as you're explaining things to me. And then I would also look at your thought content. So are you delusional? Do you have thoughts of grandeur or delusions of reference where you put key events together that don't go together, or you think people are after you when they're not? Are you paranoid? Hallucinations, are you seeing things that aren't there? Are you hearing things that aren't there? What about, phobias, obsessions? I would absolutely want to know how safe you are. So in your thought content too, I'd want to see if there's any suicidal ideation or intent or homicidal ideation. I want to know that you are not a danger to yourself or others. That would be a priority. And lastly, we would look at this sort of other category. So your health habits. What's your sleep like? How's your energy level? Any issue with urination or bowel frequency? Do you smoke? Want to look at your nutrition. What's your appetite like? How's your weight, your eating patterns, chewing and swallowing problems, types of preferences you're noticing. Your daily activities, are you able to do the thing like wash yourself, get dressed, all the activities of daily living that many people might take for granted? Are you getting them done? And then medical history, anything that stands out in your medical history. These things all together would kind of give me a good picture of where we need to go. It would also give me a good idea of what types of disorders I would want to rule out. And so to be clear, when I say rule out, what I want to rule out, it means that it's something that you might have that I need to rule out. So I could see that you came in and you're presenting like maybe you have clinical depression, but I'd have to rule out substance abuse because substance abuse could also look like clinical depression. And so I'd want to rule that out. And once again, this is just a very basic overview. I have no expectations that you guys would know how to do an intake. I just want you to recognize the process involved, because when we look at the different symptoms of the different disorders, I want you to know kind of what we're doing to go about determining whether or not somebody has a particular disorder, and if so, what type of treatment they might need and what the duration of that treatment will look like.